all you are aware so regarding that our that system. So please stick on your time. Finish. There is a mark for that also. If we exceed, there may be some negative marking. So please coordinate with us. And one by one, I am calling. And as per the roster, the first presenter is Dr. Subhasini M. Pardon? Oh, yeah. Okay, okay, okay. So you are the, okay, okay. You are the Deepika. Okay, please. Okay, okay, okay. Yeah. Sorry. Yes, yes. Okay, please go ahead. Yes.
Good morning, everyone. I'm Dr. Deepika. I'll be presenting a case report unveiling the hidden danger, a headache behind papilledema. A male student aged 19 years presented with diffuse headache for the past 2 years with no visual complaints. He was treated with NSAIDs at multiple places with no relief. He had no other history of chronic drug usage. On clinical evaluation, his visual acuity was 6 by 6 and N6 with normal color vision and apparently normal and equally reactive pupils. On fundoscopy of both eyes, there was mild pallor of the disc, slightly blurred margins with no fresh hemorrhages, which was suggestive of chronic papilledema. On investigating this patient, complete blood count, ESR, CRP, random blood sugar, BP, VDRL, HIV, chest X-ray, HBS, AG, fasting lipid profile, thyroid profile, and manto turned out to be normal. And non-contrast CT brain also turned out to be normal. So what is next in this patient? The patient was advised for MRI brain with orbits, which showed that there was subarachnoid spaces around the optic nerve, which were prominent, causing flattening of the posterior sclera, and there was sulcal subarachnoid hemorrhage in right high frontal lobe convexity, and partially empty sella, which was suggestive of raised intracranial tension. So is it idiopathic intracranial hypertension, which can be easily ruled out with MRV brain with orbits, which showed chronic thrombosis of superior sagittal sinus, sigmoid sinus, and bilateral transverse sinuses with multiple collaterals. And there was also partial recanalization of bilateral transverse sinus, which is diagnostic of cerebral venous sinus thrombosis, which was further evaluated and found that there was raised homocysteine levels. On treatment, later neurologist opinion was sought, and the patient was advised for subcutaneous low molecular weight heparin for 5 days and tablet apixaban with 5 milligram, which is a selective inhibitor of free and clot-bound factor 10A as well as indirect inhibitor of platelet aggregation. This helps prevent formation of new clots and dissolution of existing clots. The patient was also advised for a tablet which is a combination of vitamin B12, vitamin B6, folic acid, and vitamin D3 orally, which was advised twice a day. As you can see in the flow chart, it reduces the homocysteine levels. Other causes of headache in young has to be ruled out, which are tension type headache, migraine, cluster headaches, other primary headaches, and secondary headaches. Cerebral venous sinus thrombosis is a rare and potentially life-threatening condition, with incidence being 0.1%, characterized by the formation of blood clots in the cerebral venous sinuses, which increases intracranial tension leading to papilledema and other wide range of neurological complications. This patient was diagnosed with cerebral venous sinus thrombosis due to homocystinemia with chronic papilledema. It should also be, the presentations are also different in elderly versus younger patients. In elderly, there is depressed consciousness, mental state changes, whereas in young age patients, there is headache and vomiting as presentation. And risk factors in elderly would be associated carcinoma and dehydration, and they have worse prognosis, and reduced GCS is also present, and the mortality is higher in elderly patients when compared to the young patients. So why is this case important? Cerebral venous sinus thrombosis is a rare but serious condition that can often go undiagnosed due to its diverse and non-specific symptoms. Subtle signs of papilledema like mild pallor should not be overlooked, especially in young adults. The closest differential diagnosis in this case would be idiopathic intracranial hypertension, which can easily be ruled out by adding MRV to MRI imaging. And timely initiation of anticoagulants helps in dissolving the clots, restore blood flow, thereby reducing the morbidity as well as mortality. The take-home message in this case is that not all headaches in young patients are migrainous. All chronic headaches has to be evaluated completely, and a multidisciplinary approach involving ophthalmologists, physician, neurologists, and psychiatrists is needed for more patient-centric management. Thank you.
So I think you should not have thought of idiopathic intracranial hypertension because MRI showed subarachnoid hemorrhage. For making a diagnosis of IIH, imaging has to be perfectly normal. You can label it as a benign intracranial hypertension. Secondly, you didn't characterize the headache, what type of headache, morning headache, throbbing headache. It was increasing of change of posture, transient obscuration of vision was there or not. You know, those things should be asked for.
Yes, ma'am, we have asked for it, and there was diffuse headache for the patient, and there were no aggravating factors. He just mentioned that it was a diffuse headache, diffuse and generalized.
Usually, transient visual obscuration are there, and it's changes with the posture, you know, so those things are always there, you know.
Yes, ma'am.
Just headache in papilledema or BIH is slightly.
So for you, ma'am, is generally for your, it should be proper history in toto. So clinically, so in case of early cases of papilledema, is it possible to, what is the ideal lens to detect early, very early papilledema clinically in your setup, initially OPD setup?
Fundoscopy, sir, like
Fundoscopy is a huge one. I am specifically asking the which lens is best for the disc.
Clinically on examination. Like, sir, there would be RAPD, sir.
Fundoscopy may be a direct, maybe indirect, maybe a slit lamp biomicroscopy. Another is which one best?
Which one is best, sir? Either direct ophthalmoscopy or a slit lamp biomicroscopy.
And answer is always slit lamp biomicroscopy is with 78 diopter is the to eliminate all other vectors one. You are mentioning MRV. What is the difference between MRI, plain contrast MRI and MRV? Yes, those are very important. Okay, thank you.
Thank you.
Kunjal Gala, please. After Kunjal Gala, next is our Dr. Nomita Viji. Please be ready. Nomita Viji. Please.
Good morning to everyone present here. My name is Dr. Kunjal Gala, and I shall be presenting my poster titled Optic Chiasmal Prolapse in Primary Empty Cellar Syndrome. So our patient was a 26-year-old female who presented with persistent headache for 6 months. There was no history of nausea, vomiting, postural variations, or tinnitus, or any transient visual obscurations. She did have complaints of menstrual irregularities and infertility, for which she was on treatment. Her BMI was 26 kg per meter square. She had already been evaluated elsewhere for headache. She was advised to undergo an MRI, and she was given a differential diagnosis of a demyelinating disorder or a atypical low-grade optic nerve glioma. She was then referred to us. On our examination, we found that her vision, color vision, pupil reaction, anterior segment, posterior segment were all normal. However, on analyzing her visual fields by HFA 30-2, we found a bilateral enlargement of the blind spot along with a bilateral constriction of the superior fields in both the eyes. So we then sent an MRI for a re-evaluation. Our neuroradiologist reported it as a T2 hyperintense kinked optic chiasma with an intracellular herniation. she was diagnosed as a case of optic chiasmal herniation due to primary empty cellar syndrome. She was advised weight loss under the care of a neurosurgeon and an endocrinologist. She was asked to follow up with visual fields, and after 1 month, her left eye visual field did show significant improvement. So, discussion. What is empty cellar syndrome? It is a condition characterized by shrinkage of the pituitary. It is a condition in which the pituitary gland shrinks, and hence the sella turcica gets filled with CSF. So this can be primary empty cellar syndrome, in which there is an anatomical defect in diaphragma sellae along with a raised intracranial pressure, which leads to the filling up of the sella turcica with CSF. Or it can be a secondary empty cellar syndrome, which is seen after medical, surgical, or radiation therapy of pituitary or other cellar lesions, which can happen because of an enlarged sella due to a pituitary pathology itself, or because of erosion of the diaphragma sellae following radiation therapy. Patients of primary empty cellar syndrome are typically obese females who present with headache, visual disturbances, neurological symptoms. Most commonly, one of the associations which has been seen is idiopathic intracranial hypertension. In fact, 8 to 15% of the patients of primary empty cellar syndrome can progress to IIH. Menstrual irregularities, endocrinological abnormalities are also pretty common. Talking about chiasmal prolapse or chiasmal herniation, in a case of empty cellar syndrome, can cause mechanical tethering, kinking of the chiasma, or can cause an ischemic insult, which can lead to visual field losses. Now, this more often than not can be managed conservatively, but in case of persistent visual field defects, will require a surgical management in the form of chiasmopexy. So why this case? In our literature review, we found that more often or not, chiasmal herniation has always been associated with secondary empty cellar syndrome. We could just find one other case report like ours, which had an optic chiasmal herniation in a case of primary empty cellar syndrome. So 2 take-home messages. First is that empty cellar syndromes can present with visual field defects due to an underlying optic chiasmal herniation, and second, a clinico-radiological correlation is extremely vital. The patient came to us with a diagnosis as grave as a glioma, but what she needed was just a conservative management and weight loss. Thank you.
In case of a empty cella, okay, that's what is the evaluation process. I am asking about your evaluation process. Suppose you are showing perimetry. The
Yes.
ideal is that you can use the parameters, so we can judge. The other people can judge, or judge can think, is it real or not? That means it is a reliable or not reliable field. Can you tell me the criteria for a reliable field?
Sir, we'll be checking for the false positive, false negative, and we'll be checking for the fixation losses.
Yes.
So fixation losses, anything less than 20% can be considered.
And the size and what are the everything should be reflected
Yes,
once
sir.
you can
So
present
due
it
to
one.
the
Okay, it's okay, fine.
constraint of space.
Yes. And next, suppose that in such your patient is little is unable to cooperate with a perimetry. Is there any other method to assess the disc
Sir, it might be.
apart from your clinical assessment? Any other investigation which may help you, guide you, or documentation point of view?
So investigation.
Yes.
So we can do an OCT RNFL to find out if there is any loss.
OCT is one.
Clinically, sir, confrontation.
OCT is invasive in some patients, obese patient, there may be diabetic, may be a CKD patient, early CKD. In such cases, that sometimes it is a FFA, etc. difficult. So in FFP also not indicated, or there is
Yes.
a contraindication in such cases. Which is the next?
So OCT RNFL can be done.
Yes, OCT and NFL.
Okay. It's a nice case.
Thank you, ma'am.
You know, because I have seen so many cases with primary empty cellar which can be a co-association in IIH.
Yes.
But with the chiasmal prolapse, very rare.
Yes.
Good case.
Thank you. Yes, sir. Yes.
In your case, it was 30-2.
Yes, sir.
So should we pick up earlier? We put beats.
Okay, sir. I will.
Neurological beats are always put beats.
Just a small comment. Na?
Yes.
See, when you put the fields, na,
Yes.
put it the other way around when you are making a presentation. So just go back and see your presentation, put it that way.
Oh.
Yeah.
Yes.
So it should be that way, the right on the right. So
Yes, we'll keep it. Thank you, sir.
I just want to ask you one thing. Why did you do the visual field? Because everything was normal.
So because she had complaints of headache and her MRI had significant findings.
So you did MRI first and
So she had already been evaluated elsewhere. She already had MRI films, but the MRI findings and what we were seeing clinically, even her confrontation clinically was normal. So we were just trying to find out if we can, if there is something in the visual fields, because 30-2 would help us get a more clearer picture.
how did you corroborate the superior arcuate sort of field defect due to chiasma?
Sir, because there was a chiasmal herniation, so inferior chiasma usually has the superior fibers. So that's how we assume that because it is the inferior chiasma which is herniating, so the superior and superior temporal correlates with
It was
the.
homonymous? Or
Yes, sir.
It was homonymous.
Yes.
So usually chiasmal prolapse there will be the posterior fiber.
Yes, sir. So.
Cellized down.
Yes, sir. So if there's a compression, then yes, but if there's a kinking, the reports say that it can present with a variety of visual field defects depending on what exactly gets compressed. Okay.
Okay.
Thank you.
Our next speaker is Nomita VG. I think she is absent. Okay, we can call again and Dr. Subhita S. Rat, please.
A hearty good morning to everybody. So to discuss our study on clinical profile and factors affecting ethambutol-induced optic neuropathy in the NTEP era. So what we know as ethambutol is a very important component of the ATT regimen, being a bacteriostatic antibiotic. Though systemically safe, however, the visual toxicity has been reported back to 1960. And we also know that in India is one country which harbors most of the TB cases. But is the problem of ocular toxicity due to ethambutol magnified after the revised National Tuberculosis Elimination Program of 2016? This is why, because the newer regimen says that ethambutol now is given daily for a period of at least 6 months, included in the continuation phase, and are on fixed dose combination as per weight band as we see. Now, during the course of the treatment, the patient may lose, however, may be taking 4 or 5 tablets. But we also know that in this yellow table says there's a wide range of ocular toxicity, right from 1% to 18%, with a dosage varying from 15 mg per kg to 35 mg per kg per day. So what is the prevalence after 2016? To this, we found out literature after 2019. There have been papers reported from the south, but not from the northern India. However, papers from northern India have tried to figure out how to find out ocular toxicity as a subclinical toxicity and correlate with OCT RNFL. With this, we wanted to study our data, which were files from January 2022 to 2023 as an observational study. All of those cases diagnosed with ethambutol toxicity and had a follow-up duration for 6 months. After taking a detailed history and diagnosing them based on the absence of any other ocular cause of vision loss, with a detailed evaluation of what was the type of TB treatment taken, duration, onset of vision loss, and MRI brain ruling out any other intracranial lesions, and a detailed ocular neuro-ophthalmological evaluation was done. These patients were then treated with oral and injectable neurovitamins. Post follow-up, they were assessed whether there was visual improvement of 2 lines and at what duration, followed by the other optic nerve functions which were noted. So we found there were 83 eyes of 43 patients, pulmonary TB being the majority. Neuroimaging shows normal in 40 eyes and 40 patients, and chiasmitis in 3 patients. Majority of them were males. And what we found was that at least in 30 patients, they had normal optic nerve findings, followed by temporal pallor, followed by disc edema, and centrocecal scotoma was the most common field defect. Coming on to OCT, temporal RNFS loss was seen in majority, with a loss of macular GCC IPL complex in 39 eyes, but 44 of them had also normal macular GCC IPL, most of them who presented within 2 months of noting their visual complaints. 16 patients were only given injectable neurovitamins, but rest of them were given oral as well as zinc and micronutrient supplement to find that within 3 months there were recovery in 23 eyes but not recovered in 39. Okay, so there was 48% poor recovery, and the factors which was analyzed was delayed presentation, BCVA worse than 624, with poor renal function, diabetes, macular GCC, IPL loss at the first time, and those were only on neurovitamins. But a multivariate analysis did not show any significant correlation. What we did to them, they were followed up in our low vision services. But this study, though, is a very common and known factors. What I want to convey is we are treating a systemic disease inducing an ocular toxicity. What needs is increased awareness in treating physicians that they should screen these patients regularly who are started in ethambutol to detect subclinical toxicity. And what we as ophthalmologists need to do are this baseline tests to find out that how was the renal status, baseline zinc and copper, OCT, electrophysiological studies, and also to rule out concurrent isoniazid-induced optic neuropathy in refractory cases. However, there are other future prospects also, that why are some people only affected and not others, and can ethambutol with our little effort be totally removed? Thank you.
Good study. So what is your criteria to enroll in your study?
So we enrolled all those patients who has like bilaterally symmetrical vision loss or unilateral vision loss irrespective of the age. Most of them were beyond 25 to onwards age, even 50, 60, 70 years. So those who came with a history of diminution of vision and gave us a background history of taking anti-tuberculous therapy, irrespective of what was the systemic background, we have taken them.
Okay,
or they were referred to the neuro-ophthalmology clinic from the other departments also.
Or is there any such criteria last ethambutol for 1 month, 2 months, last 6 months?
No, sir, because it has been reported from 1 month to even after 1 month completion of treatment. Majority of them are within 3 months, but even after 1 month we have seen, and it is there also in literature.
So what is your suggestion to the physician if the toxicity happened?
So if the
Because
toxicity
after 1 month disease in active stage, what is our role as a neuro-ophthalmologist to guide the physician?
Sir, if they have not stopped, our role is write a letter to the treating physician to stop the drug first, including ophthalmologist, any of us can write. If they have stopped, we should not think that it cannot be treatable. We should make our efforts to document in OCT what is the baseline loss which has happened, then treat them with neurovitamins, including the micronutrients, so that at least how much our RNFL loss is not there, we can restore some amount of vision. First, by taking out the offending agent. Second, by stopping the chelating mechanism which has happened so far.
So they can change the regime. This is the first priority.
How did you explain those unilateral cases?
So there was no other cause. There was no other cause to explain their vision loss. We had thought if it is tuberculosis related optic neuropathy, the intracanalicular part should have an enhancement in this. We didn't do an VEP, but there was no other cause to explain how the vision loss was there. That is, but they had a history of taking tuberculosis.
That can be explained only by stopping the ethambutol and see whether it's the progression. There is no progression. Otherwise, unilateral cases, I don't know how you establish the diagnosis.
Unilateral is rare, sir.
Screening methods you suggest?
So we have taken all patients who came to us.
No. Right now you want to suggest something, screening methods for the even general ophthalmologist or...
Yeah, so for the general ophthalmologist, what we would say that those who have an history of taking ATT for a period of time, and then they have come with vision loss. But the easy clue that, like what sir is telling, that they will have bilaterally symmetrical vision loss, absence of RAPD, defective color vision, and a fundus can be normal, temporal pallor, or if they are in the early phase, they would have little bit of hyperemia with a mild blurring of disc margins, which will not be caught up in an MRI. So we all know that toxic neuropathy is always a diagnosis of exclusion. Hence an MRI also should be done. Yes, sir.
MRI is usually normal in these patients, you know.
Yes.
I haven't seen a single patient of ethambutol optic neuropathy where MRI shows something.
Ma'am, in acute stages only they may show that chiasmal enhancement, but seeing that we have not given IVMP.
Very rarely.
Very rarely. 3 of them had. So,
okay.
But majority of them it comes out to be
But
normal.
the one which have a chiasmal enhancement, they must not be having central seco. They must be
No.
having a bitemporal.
Yes, there is.
But you said you're all the patients they
not
have
all,
central
ma'am.
seco.
Not all.
Acha,
30.
You said some.
Yes,
okay,
yes,
okay.
ma'am.
Sorry.
Not all, 30, ma'am. We have bitemporal hemianopathy.
Okay,
That's us.
So which parameter was more correlating with your visual loss or visual fields, the GCC IPL loss or RNFL loss?
GCC IPL. GCC IPL, ma'am.
Just two comments I'll make. You spoke of molecular studies in the end. Though ethambutol is known to induce LHON in patients who have that
Yeah, and
gene.
I agree
So
that people have started treating it with idabenone also as a supplement because
that's-
both of them have mitochondrial
That's
mechanism.
one thing. Secondly, off late, see the importance of the paper is off late what we are doing is we are doing serial follow-ups and we have patients who are asymptomatic but having mildly hyperemic discs. And in them if you do the VEP, you get an affected VEP, the way it is for drug-induced toxicity. So I think probably VEP is an important thing to do in these tests, in these patients.
Picking up the subclinical
Yes.
cases rather than OCT RNFL because they retrobulbar optic neuritis. So to show off the RNFL loss in GCIPL will take some time. So the functional tests are much better than the structural one.
And even in the OCT, I don't know if it is the RNFL that's more important or is it the ganglion cell complex that's more important.
Ganglion cell. Ganglion cell, sir.
Can you give the reason to the audience why GC
Because the
IPL
structural damage always occurs before the functional loss is there, and that those PMB are more affected because they have those parvocellular axons, which has more firing in the brain. This
I think the cause is that like ganglion cell have a larger diameter, 12 to 15 micrometer,
Microns.
and while RNFL is 1 to 2. And GCIPL is a 5-layer thickness at macula. That is a single layer thickness at the peripapillary area. So to pick up the loss by OCT is much more
earlier.
in ganglion cell layer than in the RNFL. That is the one reason they say.
Okay.
I have a question. Like, when are we supposed to get the field test after the stopping ethambutol? After how long we are supposed to wait and repeat the field, whether it is progressing or regressing, or whether
2 months after the stopping of the treatment, then it doesn't progress much. And recovery takes 1 year at least, 6 months to 1 year. So till 1 year, we should tell the patient you will get the vision by the end of 1 year.
so how much recovery have you seen?
Oh, we have seen 6/6 also some cases. Most of the cases, I have seen 6/6.
Yeah, I think I would second that. Most of the cases get 6/6. Literature says that it is not that way. But if you really follow up a patient for long, you do get 6/6.
6/6.
The only patients who don't happen to be 6/6 are those who have an extensive renal function loss, is what, or those who have the LHO.
Diabetes or something, yeah, LH1. Yeah.
Our next speaker is Bose.
Is there any role of concurrent use of multivitamins with the anti-ADT? Is there any role of concurrent use of multivitamins along with ADT?
B6 you always give because Isonex is known to
Never
cause
pro-
pyridoxine deficiency.
After getting ethambutol toxicity, that's why we are giving those. We are not.
Zinc
going
and copper are supposed to be because it's supposed to chelate both of these,
something
and which
should
are
be-
important in mitochondrial, oxidative phosphorylation.
So why not prophylactically? My point is this: if you have some,
Because not all the patient on ethambutol will develop toxicity.
that's why we are saying there is no harm in giving. We are one extra tablet. So this is because some study should be done on this.
Can think of.
And one thing more, we should not more rely on the OCT because OCT is like this again. We don't know what is happening. You repeat OCT after 1 hour, same OCT will be different OCT.
Yeah,
So
agree.
there are so many AI and so many things there. So that's why the other physiological tests are more relevant than the OCT.
Yes.
Good morning, everyone. So today my case is prolonged functional vision loss in a case of pediatric migraine. So headache is a common complaint among adults who present in ophthalmology OPDs, while children can also sometimes present with a complaint of a headache. If headache is associated with vision loss, it may signify an underlying grave pathology that needs an immediate and thorough evaluation. History and chief complaints of our case. We have a 7-year-old male child who complained of a right eye blurriness of vision for the past 1.5 months. He said the vision loss was painless, progressive, and aggravated in the last 2 to 3 days prior to presentation in the OPD. It was associated with a complaint of intermittent headache for the past 5 months, and his mother complained that there was an increased irritability to light and sound for the preceding 5 months. There was no previous history of any seizures, weakness, major illnesses, or trauma. On clinical examination, his BCVA with cycloplegic refraction was plano 624 N18 in the right eye, while plano 66 in the N6 in the left eye. Color vision, he was not able to read any of the plates in the Ishihara chart in the right eye, while left eye he read all the plates. EM was full, free, and paleness. Pupils were round, reacting to light. There was a stress RAPD in the right eye. The anterior segments in both the eyes were normal. Optic disc was show the VCDR of 0.3 and healthy neuroretinal rims in both the eyes. Periphery and fovea in both eyes were within normal limits. So we attempted a visual field in this child. Though both eyes visual field had a low test reliability, the right eye had a concentric visual field defect, while OS has a superior arcuate kind of defect. We did a OCT RNFL, while the right eye had a temporo-inferior thinning, left eye had early temporal pallor. On the basis of the headache and the vision loss, he was advised an MRI brain and orbit, which was found to be within normal limits, but the child complained of worsening of headache and the vision dropped to finger counting close to face. So the child was immediately referred to a pediatric neurologist who underwent further evaluation after hospital admission. They repeated the MRI with a contrast enhancement and found few tiny non-specific cerebral white matter hyperintensities, and the rest was within normal limits. They had an MRV done, which was noted to be within normal limits. Both eye VP was done, which was within normal limits again. The blood for CBC, serum vitamin B12, and homocysteine came out to be normal. The child underwent psychiatric consultation there and revealed behavioral abnormality, which significantly improved with the counseling. The diagnosis made was a pediatric migraine with functional overlay, and he was treated only with NSAIDs and vitamin supplements apart from the psychiatric consultations, and was discharged from hospital after 36 hours with no headaches and a full visual recovery of the right eye vision. He was discharged with anti-migraine prophylaxis and lifestyle modification advice on discharge, and when he presented back in our OPD, the VCVA was noted to be 66 N6. The color vision was normal in both the eyes. There was no RAPD, and both anterior and posterior segments was within normal limits. So, as per literature, visual disturbances in migraine can have varied presentations, including monocular vision loss, which is mostly transient, but however can be prolonged. Affective disorders are often, like depression or anxiety, are often coexistent in migraine patients and need concurrent evaluation and treatment. MRI brain findings in migraine have shown non-specific deep white matter changes and pupillary findings, which has been noted during the migraine attacks. Conclusion: while migraine can be a common cause of headache, other organic causes of headache and vision loss needs to be ruled out prior to making a final diagnosis of migraine. Functional vision loss should be kept in mind while dealing with migraine patients, as they might have concurrent affective disorders. These have been my references. Thank you.
On what criteria? This is key point to diagnose, ultimately label as a migraine.
So first of all, he was complaining of a headache, and it was a bilateral headache as per him, because he was showing like both my sides are paining, which is often seen in pediatric migraine cases. And there was a vision loss. Though you are saying there is a bloodiness of vision, we know that sometimes migraine with aura can have a vision loss present. So, and on the basis of pupillary findings, there have been reports that there can be stress RAPDs, or there can be benign episodic mydriasis of the pupils. So, those were those criteria.
Okay. So, and just one technical point. In one of your slide, you mentioned MRI plane. P means plane.
Yes.
In which condition? In pediatrics, generally we offer, if you want to undergo that MRI, it should be MRI with contrast. The reason is most of the time under sedation or short GA. In which condition you can directly advise, only few conditions you can advise MRI plane. What are the criteria to say MRI plane?
If there is some concurrent kidney disorders, or
in your case?
Not my case.
Madam, your opinion regarding.
So, just See, when you put these sort of cases, now it will be good to have the fundus image.
Yeah, sir, because at that point of time, our
Yeah.
hospital didn't have a very good fundus camera.
The second thing is, what is the cause of the RAPD? I'm wondering, since you said RAPD. I mean,
So,
ever since you said RAPD,
I
what
have,
would be the cause?
actually, I am also not very sure, but I have read that in case of retinal migraine attacks, when there might be decreased blood supply to the optic nerve or the retina, there can be a trace RAPD.
Because there is vision loss, there is RAPD, there is a color vision loss.
Yes. So,
And then you are calling him functional.
yes, that's why he was advised an MRI urgently, and the MRI also repeated to find out if there was actually any organic lesion. But they didn't find any. The only thing they found was the deep white matter lesions that is often seen in migraine patients.
I think fundus examination at the time of decreased vision is very important, because if you are suspecting retinal migraine, there would be narrowing of the retinal blood vessels. So that's
You
important.
heard of this entity called benign episodic?
Episodic unilateral mydriasis.
Yeah.
So you want?
I don't know if it's that, but
It
in that
might
you
have been
don't
that.
get color
I also
vision.
thought in on the hindsight, I also thought that it might have been BUM, which I had because the child was not cooperating well. So it might have been that. I would have thought it's an RAPD, grade 1 RAPD.
Can I take one question? You have used a very generic term, migraine. In migraine, if you divide broadly also, there are 4 types. It may be tension headache, maybe cluster headache. And by definition, migraine is usually unilateral.
Yes.
And there's something.
Outside, you can ask, but we will not include in our survey. Okay. So now your is over.
Yeah.
Marking is over. Now we can.
This was contributing for the
Yes, yes,
subject.
please, please.
Yeah, science.
Please, please. Now we can. Now you are free. Your is all done. So then you can. No, you can answer. You can if you want.
So, by definition or otherwise, it is not going to be. Sometimes what happens, if doctor is so much into literature and read so much, so sometimes it goes to the patients. हम ज़्यादा पढ़ लेते हैं कई बार वो भी एक syndrome होता है. So there are some simple things are there. So maybe functional for some child are there, but in functional we can also rule out those things. Yeah, thank you.
Dr. Shravani? Not reported.
A very good morning to everyone. So my topic today is pupil size in migraine with photophobia versus normal subjects and photochromatic glasses role in migraine. So as you know, migraine is the 3rd most common disease in the world, and almost 1 in 7 people are affected worldwide. It has a core component of photophobia in 80% of the cases, and in 1/3 of the migraine patients, bright light is the triggering factor. So why does photophobia happen in migraine? There are many theories like cortical hypersensitivity to light, altered ocular parasympathetic outflow, intrinsically photosensitive retinal ganglion cell, but we wanted to study what is the role of the pupil size in migraine. So our study the purpose was to compare the pupil size of patients having migraine with photophobia versus normal subjects, and to evaluate the role of photochromatic glasses in reducing the MIDAS, that is the Migraine Disability Assessment scores. It was a prospective case control study. 100 eyes of 50 patients with migraine were compared with the same number of normal subjects in the age group of 20 to 30 years with a male to female ratio of 40:60. The visual acuity was 6/6 without any significant refractive error. There was normal anterior posterior segment evaluation. Patients did not have any neurological conditions or trauma, and they were not on any medications or eye drops. It was a single observer who measured the pupil size with the help of IL Master 700. Undilated photopic pupil size measurements under similar light settings were done in both cases and controls. MIDAS scores were obtained in all cases before and 3 months after prescription of the photochromatic glasses. So coming to the results, we found that the mean pupil size in patients with migraine and photophobia was 4.89 millimeters as compared to the normal subjects who had a mean pupil size of 3.8 millimeters. Now, coming to the grades of MIDAS severity, we found that patients who had grade 4 MIDAS or the most severe type of disability had the largest amount of the mean photopic pupil size, that was 5.6 millimeters. Now, in this study, we have not included any patients with physiological we have not included any patients who have had anisocoria. So, all the patients were having physiological anisocoria within 0.4 millimeter difference between the two eyes. But amongst them, we found that in 80% of the cases, the larger pupil size correlated with the side of the headache. Now, the effect of photochromatic glasses in migraine patients, all the patients who took photochromatic glasses, we found that 90% of them had a reduction in their MIDAS scores, whereas 10% had no change in their MIDAS scores. So this is the first study comparing the pupil size of migraine patients with normal subjects. According to the MIDAS scores, we have seen that the pupil size in the patients who have a MIDAS score of 4 has been the largest. There have been few other studies where transient unilateral mydriasis or AD's pupil has been reported, and this has been linked to the dysfunction of the autonomic nervous system. But this study shows that maybe an intrinsically larger pupil size could be a trigger factor for migraine. There have been studies where use of tinted glasses like rose K and blue light filters have been used in migraine because it has been seen that certain wavelengths of light, for example blue and red, they trigger migraine attacks more frequently, whereas green light has been seen to be more soothing. But in our patients, because sunlight was the main factor involved, we have used photochromatic gray glasses, and this has helped to reduce the MIDAS score significantly. So conclusion of this study is that the pupil size in patients of migraine with photophobia is larger as compared to the normal subjects, and this could be a trigger for the migraine attacks. And photochromatic glasses can help reduce MIDAS scores in migraine patients and can be a potential method of treatment in such cases. Thank you.
You use the IOL master to measure the pupil size.
Yes, ma'am.
I think infrared pupillometry is a more scientific way of measuring the pupil size.
Yes, ma'am. Actually, we didn't have an infrared pupillometry,
Okay.
and we also found a study which has been done by Shi and Yuan, which says that infrared pupillometry, as compared to IOL master, has seen to have almost similar pupil sizes in both. So, considering that, because we had the IOL master 700, and we were seeing that there is a difference in the pupil size, so we did the study with this. But
I don't know, scientific literature says infrared pupillometry is the superior to this.
Yes, ma'am, definitely.
Okay. Otherwise, nice study.
Excellent one, good. But I want to know regarding that, whatever as Madam told, infrared is main. But if we are comparable, only you can control the room light.
Yes.
That is for IOL master is easily available in every setup nowadays. So in such scenario, what is your recommendation to the others to room light adjustment?
Where we had measured, it has just an ambient room light setting, because we wanted to see that whether actually the idea for this study came from a patient who had started to develop migraine attacks after a traumatic AD's pupil. So the patient had never had any attacks prior to this, but we found that when we gave diluted pilocarpine, the MIDAS scores completely went from MIDAS 4 to MIDAS 1. So the patient was able to go out in the sunlight, and so just we had an idea that whether their pupil size has any correlation, which might be a trigger factor to cause the headache. So that is why we went for this study. And we found that actually there is a correlation. That means that only those patients who are having a very higher amount of disability which are in the grade 4 category, but definitely having a size which was larger.
Yes, fine. That I want to know that you can just tell to technician basically the amount of light and what and the type of the light. Then it will be neutral for all. Then you can for your correlating. So on that particular room, the same amount, same light should be in all the patients.
All the patients.
Then
Yes. That's
okay, fine.
Thank you.
Good morning. I'm Dr. Tavish Gupta, and I'll be speaking on navigating optic neuritis secondary to breast cancer treatment. So we're presenting a 41-year-old female with diminution of vision in the left eye, which was sudden in onset and it 1 day ago, and it was associated with pain on ocular movements. There was no history of trauma, no history of headache, and no other positive history in the patient. She had a significant systemic history in which she was diagnosed with breast cancer in January of 2022, for which she underwent a breast conserving surgery and lymph node biopsy, which was followed by radiotherapy treatment and chemotherapy treatment. And currently, the drugs the patient is on is the TAP gabapentin. On examination, the right eye was within normal limits, but in the left eye, the visual acuity was 6 by 36, and the color vision and contrast were also reduced in the left eye. The pupil showed a relative afferent pupillary defect in the left eye, and on the fundus picture, we can see that the left eye, there is disc edema present, and it's a unilateral disc edema, and the right eye is normal. So, considering the history of breast cancer in this patient, we looked up some reports, and we found that metastasis to the optic nerve can present as optic neuritis in such patients. So, we further investigated the patient. First, we did a visual fields testing in which the left eye showed a focal visual field deficit, and then we went on for a contrast enhanced MRI of the brain and orbits. We wanted to look for tumor cells in the we wanted to look for optic nerve thickening in the CE MRI, which would show that there is metastasis to the optic nerve. But we did not, but in the MRI, we found the typical findings of optic neuritis only, in which there was T2 hyperintensity along with fat stranding, which was present. And there was no other evidence of metastasis seen anywhere else in the brain. Now we went on for a CSF analysis to look for tumor cells in the CSF, which were absent, and there were no and all the CSF findings were all normal, including the infectious test for infectious disease as well as the CSF protein and glucose. As part of the routine panel, we did blood investigations also, in which we were surprised to find that the anti-MOG antibodies were strongly positive in this patient, which is quite rare. Now, and as we did not find any metastasis and we found an optic neuritis with an anti-MOG positive antibodies, we started the patient on intravenous pulse methylprednisolone, which was given 1 gram for once a day for 5 days, followed by oral prednisolone 1 milligram per kg. And with this, the patient improved with the best corrected visual acuity of 6 by 9, and the color and contrast sensitivity also improved. And in the on the fundus CP also, 1 week later, the disc edema is resolved. Now the discussion. In the beginning, we thought it's a unilateral vision loss. So from the history, it could be due to retinal detachment, central retinal artery occlusion, optic neuritis, or a non-arthritic ischemic optic neuropathy. But due to the characteristic pain on extraocular movements, which was later confirmed on imaging also, we diagnosed it as optic neuritis. Now, why is this atypical? Because the patient has a history of cancer also, and she has undergone chemotherapy also, and drugs such as paclitaxel, which are used, they may also cause they are also known to cause optic neuritis. But in this case, the atypicality was due to the MOG positivity, which is again quite rare. So the cause of optic neuritis in patients of breast cancer can be divided into oncological causes and non-oncological causes. The oncological causes is the most important one, which is the metastatic involvement of the visual pathway and the optic nerve, in which the thickening of the optic nerve is seen, or we'll see tumor cells in the CSF. It can also be due to the ocular toxicity to paclitaxel and other chemotherapeutic agents used in breast cancer chemotherapy, and due to the radiation-related side effects. But we should also consider the non-oncological causes and take a detailed history and investigate for any toxin-related optic neuritis, or due to a B12 deficiency, or if it's due to a multiple sclerosis, or due to an infectious disease also, as we saw in this case. So in conclusion, breast cancer-related optic neuritis is quite rare, and most of the cases which are reported are due to metastasis to the optic nerve. And it is quite important to look for optic nerve thickening, as metastasis to the optic nerve will indicate that there is metastasis following the breast conserving surgery, and it will further guide our treatment. But we should also see for other causes of optic neuritis in such patients, as early detection of the optic neuritis due to other causes, such in this case such as MOG antibodies, which has not been reported before. And in this case, the early detection with the prompt administration of steroids helped in preserving the visual acuity of the patient. Thank you.
What about the oncological causes you have shown?
Yes,
That
sir.
is, one is the metastasis and other two is the ocular toxicity due to the
Chemotherapy.
treatment and the radiation therapy, but it was unilateral.
Yes, sir.
The last two causes, it's ruled out. So only can be it's the metastasis. There was no metastasis.
Yes, the patient actually had a presentation of 1 day, so it might be a delayed it could have been a delayed bilateral also, because we.
Let me just finish. So
Yes,
it
sir.
was not metastasis.
Yes, sir.
So oncological causes, whatever the causes, it's ruled out. So
Mm.
can it be just coincidental?
Yes, sir, that might also be there, and it might be coincidental also. It might be due to the stimulation of the autoimmune system of the patient due after the breast cancer therapy also, which has not been studied before, will need future study.
Should be bilateral.
Yes, sir.
Nice presentation. I like the way you put your thought process over there about causes of decrease of vision. I just had this one point. I don't know, maybe it is for the other judges here. What would happen to the MOG antibodies in a patient who is breast cancer patient or a patient who has been treated for a breast cancer? Because all these are immune related, number one. Number two is, there is an entity called paraneoplastic optic neuropathy.
Yes, sir.
So, would this be that?
No, actually, sir, we had investigated in the blood investigations also. We had investigated for paraneoplastic antibodies, which also came negative in this patient.
Okay.
So that was also there in the blood investigation. So that was negative.
Fine.
Classical of MOG, because in MOG you get demyelinating plaque,
Yes, ma'am.
and then you get fat stranding.
Yes, ma'am.
That is supposed to be in the MOG MRI. You know,
Yes, ma'am.
I think it's nice presentation.
Thank you.
Thank you. Our next presenter, I invite our next presenter, Gulfasan Khanam.
Good morning, everyone. Today I am presenting a case report of secondary idiopathic intracranial hypertension presenting during the treatment course of VKH. As we already know, Vogt-Koyanagi-Harada syndrome is a primary autoimmune stromal choroiditis, can be associated with meningeal, auditory and dermatological symptoms. The treatment of choice being steroids and newly recommended combined steroidal and non-steroidal immunosuppressive agents. Non-responsive refractory cases are treated with biological therapy. Idiopathic intracranial hypertension is also known as pseudotumor cerebri. It's an uncommon condition of increased intracranial pressure that most often affects young obese women, frequently associated with headache, visual loss secondary to papilloedema. It is a diagnosis of exclusion. Idiopathic intracranial hypertension can be possibly caused by chronic steroid use, by increased CSF viscosity due to increased protein content, and weight gain from prednisone. Coming to the history, a 40-year-old female diagnosed with granulomatous panuveitis elsewhere 8 months back was on chronic systemic steroids on and off without complete recovery. She presented to us with both eyes diminution of vision and was diagnosed with VKH based on clinical features, OCT and B scan, and started on systemic steroids. 2 weeks after starting steroids, patient shows improvement in vision and was advised to continue steroids. After 25 days of therapy, she developed headache, consulted neurologist and was diagnosed as IIH and was advised to taper and stop steroids. 7 days after stopping steroids, she is complaining of gradual, progressive, painless diminution of vision of both eyes. History of left ear surgery 5 years back, details not known. She is hypertensive since 15 years on treatment. Coming to the ocular examination, the visual acuity of the right eye is 618 with pinhole improvement to 612. Near vision is N10. Left eye, the visual acuity is 618 parts to pinhole improvement 618 and near vision is N10. Slit lamp examination shows vitreous cells in both eyes, and fundus examination with indirect ophthalmoscopy and 20D lens. As we can see, the disc is edematous and macular. There is edema and multiple SRF pockets were seen, and vessels were tortuous, normal in caliber, and periphery shows multiple SRF pockets. And on macular OCT with HD 5 line, it shows multiple neurosensory retinal detachment with RPA undulations. And visual fields of CETA standard 30-2 with reliable parameter shows enlargement of blind spot with patchy reduced retinal thresholds. On an MRI, there is prominent CSF space along the optic nerve sheath on either side, with there is a flattening of the posterior sclera bilaterally, and there is empty cella sign. And summary, a 40 years old hypertensive female, which is a known case of granulomatous panuveitis, diagnosed with VKH based on clinical features, OCT and B scan, started on oral steroids. 25 days after starting oral steroids, she consulted neurologist with complaint of headache and diagnosed with IIS secondary to steroid use, and was advised to taper and stop steroids. 7 days of stopping steroids, she presented to us with complaint of bilateral diminution of vision with multiple SRF pockets, disc and macular edema on fundus. OCT shows multiple neurosensory retinal detachment with the RPE undulation, and visual field shows enlargement of blind spot with patchy retinal threshold, a reduced threshold. Diagnosis is chronic incomplete Vogt-Koyanagi-Harada syndrome with steroid-induced secondary idiopathic intracranial hypertension. We managed this patient with immunomodulator methotrexate 10 mg weekly along with low dose oral steroid 10 mg. And after 1 week, vision was improved to 6/9 of both eyes. Vogt-Koyanagi-Harada syndrome is a primary autoimmune stromal choroiditis, may be associated with meningeal auditory dermatological symptoms. Our patient was diagnosed with granulomatous panuveitis and further with VKH, and on treatment with chronic oral steroids, she developed headache, and on neurology referral, she was diagnosed with IIH with increased CSF pressure and flattening of the optic disc with prominent CSF spaces around the optic nerve with empty cella. And after stopping the oral steroid, she again developed the same symptoms. And this IIH can possibly caused by chronic steroid use by increased CSF viscosity due to increased protein content and weight gain from prednisone. And there is one more study, Siddharth Gul et al. With a rare case of chronic idiopathic demyelinating polyneuropathy. The patient was on chronic steroid regime and frequently developed headache and blurring of vision with diagnosis of IIH with increased CSF proteins and systemic response to acetazolamide and elevated opening pressure on the lumbar puncture supported the diagnosis of IIH. So we conclude, we aim to emphasize the importance of keeping IIH in differential for a headache in chronic VKH patient on steroid as a possible complication of preventing catastrophic outcomes. Combined steroidal, non-steroidal immunosuppressive therapy can be considered for treating chronic VKH. These are my references. Thank you.
So good presentation, but I want to know, is a competitive session. Suppose there is a Vogt-Koyanagi, first line of treatment is steroid. In such cases, what? As we know that there is some steroid related complication. To avoid those, what will be your protocol?
Sir, actually we can start with steroid first, as our patient was on chronic systemic steroid since 8 months, on and off. Because of chronic steroid use, there is increased CSF viscosity might have happened with increased weight gain.
I'm just asking, what would be our protocol if we start steroid? We can instruct some few things to the patient to avoid the complications.
After starting steroid, we should ask the patient to, if she has any complaint of headache or increased weight gain, we should monitor the patient. If she is having any kind of complication, we can reduce the systemic steroids and can start non-steroidal immunosuppressive agents along with low dose steroids.
Yes. Apart from some others, like a diet, proper control of the blood pressure, proper control of sugar, chronic renal function test, periodic renal function test, those are the points. If we can do, generally we can avoid most of the time. She or he can do some physical activity daily, low carb food, proper water intake, and that dietary balance. That's important. Okay. Any question?
So excellent point made by sir. So I deal with a lot of patients of uveitis, so we end up using steroids quite often. These are all the instructions that we need to give. Actually spend 5 to 10 minutes to ensure that the patient doesn't gain weight because of steroids. Number one. Number two, in VKH, so that is looking like VKH, and it is good that you've done the lumbar punctures, otherwise we would have called it headache and meningismus related to VKH. What's new about VKH, or probably even known now, is that you start immunomodulators right up, straight away. So when you get the first or second attack, you just straight away start the patient on an immunomodulator. And probably the drug of choice is Azoran. Here you have used methotrexate, but the response seems to be fine. Maybe the response is right now to steroids, because you've shown it only at 1 week. Methotrexate wouldn't have acted in 1 week, but nonetheless, good presentation.
Monica Singh.
Good morning, everybody. The study I did was peripapillary vessel density if it's a collateral damage in papilledema in IIH patients. So to begin with, we know that papilledema is a passive swelling of the optic disc secondary to the raised intracranial pressure. IIH is a diagnosis of exclusion and characterized by headaches, pulsatile tinnitus, papilledema, and normal CSF. The primary morbidity from IIH is irreversible visual loss due to chronic papilledema. OCT is a non-invasive interferometric technique for cross-sectional high-resolution imaging of retina. OCT angiography is a newer modality which is for identification of blood flow changes in retinochoroidal vascular network. So previous studies have hinted on changes in the superficial vessel density in the peripapillary and macular areas in optic nerve diseases, but they have not quantified it. The quantification of vessel density is still minimally explored area. So in our study, our aim was to evaluate the peripapillary vessel density in idiopathic intracranial hypertension patients with regressing papilledema using optical coherence tomography angiography. Our methodology was, the study design was cross-sectional prospective case control population-based observational study. Sample size was 20 patients with 20 age-matched controls. And study duration was 6 months at our Ophthalmology OPD in Srihar. The inclusion criteria was age more than 18 years, patients diagnosed with IIH on treatment and multiple follow-ups showing regressing papilledema, normal CSF analysis and neuroimaging showing no specific lesion and normal MRV. Exclusion criteria was significant media opacities, optic disc edema due to causes other than IIH, and glaucomatous disc changes, patient not willing to participate. Method was visual acuity, IOP, anterior segment dilated fundus examination, and it was done, dilated fundus examination was done by slit lamp biomicroscopy and indirect ophthalmoscopy to confirm bilateral optic disc edema. Fundus photo and OCTA was done. So we did OCTA on Cirrus spectral domain. The NIH publicly accessible software image J was implied to on angioplex RPC images to quantify the vessel density within the peripapillary area. Images were made binary, skeletonized, and then vessel density was calculated. So this is image. We binarized it, then we skeletonized it, and then we calculated the vessel density using the software. So in our study, we found that the group with the resolving papilledema have increased vessel density as compared to controls, significantly in the inferior nasal, and superior nasal peripapillary vessel density. So in our results, we saw that whole vessel density inside inferior nasal and superior nasal, we had significantly this increased vessel density. So we have seen in studies that FFA or ICG, we cannot quantitatively visualize the peripapillary capillary networks. So, and in another study we saw by Torres et al., they demonstrated a decrease in the skeletonized peripapillary density that correlated with increase in papilledema grading using the OCTA. So, similar study done by Kaya et al. Has a statistically significant increase in vessel density in superior nasal and inferior nasal regions with OCTA in IIH patients with resolving papilledema compared to the control group. So, enhanced vascularity at the nasal and inferior localization in our study could be explained by the dilatation of vascular structures secondary to elevated ICP. So for conclusion, the IIH patients display vascular abnormalities specifically in the inferior and nasal region, which can be detected and quantified by OCTA. The measurement of vascular density acquired from OCTA may shed light on the pathogenesis management and monitoring of the consequences of elevated intracranial pressure on the ocular vasculature. The limitations of the study were like small sample size. We didn't have a subjective assessment of the regressing papilledema and lack of quantitative objective tests. It is an expensive and non-routine investigation, so we cannot do it multiple times. And long-term studies with follow-up are needed to determine the prognostic value of OCTA, since it's a newer modality with expensive for patients with IIH, and we cannot do it too many times. Thank you.
In one of your slide, you mentioned CSF analysis.
Yes, sir, normal CSF.
Normal. In all cases or in few cases?
Sir, in all the cases I took, CSF was normal, sir.
What is your protocol? So you send to the neurosurgeon or?
Yes, sir. We collaborated with the neurologists to send us patients who have started the treatment for the IIH, and then we saw their like we have seen them already, and then we follow up with them with the regressing papilledema. Then we did the OCTA to see the vessel densities.
What we can look for during the CSF analysis in such type of patient?
Increased pressure, sir.
By what method?
Opening pressure, increased opening pressure, lumbar puncture, sir.
Definitely lumbar puncture, but
yes, sir.
That's a point actually.
Okay, sir.
So if you refer to the neurosurgeon, most of the time neurosurgeons in a busy schedule is impossible to do themselves.
Yes, sir.
They refer to some technician. That's one false.
Okay, sir.
You can do it in your, so you just because anesthesiologist earlier during the LSCS section, they are very much tuned with this lumbar puncture.
Yes, sir.
They are more professional on lumbar puncture. So you can assess the thing in your clinic. Call the anesthesiologist in your OPD with proper care. The same, only the aseptic point, and you can assess the flow. You can check the flow, and if they do the lumbar puncture, it is more accurate than neurosurgeon.
That's true, sir. I agree. Thank you, sir.
Any more questions?
I think this tip is a best idea, and I think this is whole like a diamond for me for conferences.
It is easy for patient will be in your hand. Moment you can send that there is a trust with the patient who is gone to their thought is a neuros or nerve disease.
Yeah,
they will not think for that. So I generally call my anesthesiologist in front of me. So do that thing. So they are very, very perfectly they can do, and you can assess everything.
One thing also, you can record it also for later review, and this is, I think, a very good tip, and for my Pesa Vasool tip for this conference.
Yes, thank you, sir.
Excuse me. You said that you took the cases of regressive papilledema. Why not the fully developed papilledema cases? You said the density increased, then the control.
Yes, ma'am.
So
it came back. Like usually there is a decrease in the vessel density.
you did the basal and you followed up those patients. You said cross-sectional study.
I followed up the patient.
But you said cross-sectional.
We did not do OCT angiography at all the points. We did it only when the papilledema was regressing. We wanted to see that because it's expensive investigation, so not everybody.
Okay then. Okay.
We are already behind the schedule. Our last speaker is Dr. Sinmay. I think, madam, is not competitive, non-competitive. your is under session? Competitive session? Okay, fine. I thought.
A very good morning to all of you. I'll be speaking on the supranuclear and central eye movement disorders, a case series, no financial disclosure. The aim is to describe the clinical features of supranuclear and central eye movement disorders, which are a rare group of eye movement abnormalities and the factors that aid in the diagnosis. So it's a retrospective observational case series of 14 cases from a tertiary hospital in South India over 6 years. Standard neuro-ophthalmic and neurologic examination were done, and the cases were managed conservatively. These were the cases, and the age group ranged from 8 to 75 years, and various diagnoses were found. As you can see, the majority of the cases were internuclear ophthalmoplegia, but we did have other cases as well. So why I want to highlight on this is that we all know the PPRF, RIMLF, interstitial nucleus of Kajal, and all those things, and they are present within a very small area of the midbrain and pons, and rarely we get clinical, the diagnosis picked up on the MRI. So they just give lesion around thalamus and all, but we cannot pinpoint that particular area. So this is a case of internuclear ophthalmoplegia, left abduction, everything is normal. As you can see here, left eye adduction is abnormal, and there is a abducting nystagmus on the right side. So again here, the imaging just bleed around thalamus, midbrain, that's the kind of imaging that is given. Ideally, we need a functional MRI, but many patients, many centers are not equipped, patients may not afford. So clinical examination to pinpoint the diagnosis is the crux of treatment. And here again, this is a patient with hypertension with multiple bleeds intracranially, but again, the diagnosis does not get pinpointed, and it's a case of vertical gaze palsy. And this is another patient, known hypertensive with vertical gaze palsy. As you can see, it doesn't move up and down. Horizontal movements are also limited to a certain extent. So the upper lid retraction is also seen in this case. And this is an 8-year-old child with dengue encephalitis, and here you can see the convergence retraction nystagmus. That's a very rare thing to see. And most of the time, these things are missed on diagnosis unless we know that this is a thing. Even he had squint and like it was very differing at different points of time with limited extraocular movements. So here again, he had some signal intensities noted in the medulla and the pons. This is another child with SLE who was studying in 10th standard that time and had problem with reading. And here also there were micro bleeds around the pons and the middle cerebral area. And you can see her convergence is perfectly normal. She can see the convergence, she can converge, but when we are putting on the accommodation, the near vision, that is when she finds it abnormal. And then again, when we put the glasses, she can get her near point of accommodation closer. So this is our house surgeon with the divergence insufficiency who was treated with the base out prisms. So to conclude, understanding the complex eye movement disorders helps us in localization of the lesion in the brain, because most of the time the imaging that we get will not give us, will not pinpoint us to the particular diagnosis, and it is, although it's an era of investigation, I feel it's still coming back to the clinical examination where we have to pinpoint the lesion. Again, it is very, very different to tell within that small 1 by 1 centimeter area which particular center it is. Is it RAMLF, is it INC or PPRF, like that? But it's important for us to understand. The treatment, however, is conservative, and prisms sometimes and glasses, as in this last case is given. For most of the other patients, it's mostly observation. Many of them are debilitated also. These are the references. Thank you.
Follow-up, are you prefer videography or photography? Which one, as per your choice, which one best?
So generally I take videos and photos, because many times I feel I may not have understood what is exactly happening to the patient, because we do not know everything. So if you have a videography, you can again go back and check.
in all patients, you are preferring videography in such complicated cases?
Yes, sir. Most of all the patients I take video, and as somebody else also mentioned, since we also don't have the IR photography, most of the times for the measuring the pupil, like in the accommodation insufficiency girl, she did not have the pupillary involvement, which was very surprising. So that will fix our diagnosis only to the ciliary muscles, and it spares the pupil, but only the ciliary muscle is getting affected, and it rules out ADs also. So I also take readings either on when we didn't have. Yeah.
As it is a competitive, I'm asking one
Right,
question: what are the advantage of videography over photography?
Even nystagmus and all, we can slow
Yes,
and check. So I did get one Fresnel goggles. Like I did not have Fresnel goggles, but I just made the optometrist do a 20 power glass.
Fine.
And
Technically,
check.
one advantage is that we can freeze it and we can use
yeah,
the
we can
photography.
freeze,
We
do it
can
in slow
freeze
motion
and then
then
freeze and we can
check.
do that one.
Yes.
That's very, very important. And
Yes,
yeah.
You said you had a patient of accommodative insufficiency.
Yes, ma'am.
And you found the lesion?
Ma'am, the MRI gave the lesion as pons and
Pons,
MCP.
I think this accommodation should
Yes,
not
ma'am.
be there.
It is under
Pons,
in the MRI. It was given like that, ma'am. But that's what she had.
exact
SLE.
accommodation center is not known, but
Yes,
there's a
it is-
triad
yes,
of
yes.
neuroreflex.
Yes.
So
She had multiple bleeds in the whole of white matter. Like pinpoint bleeds were there.
yeah, there might be a micro
Some
bleed
micro
over that
bleed
area
over
of the third nerve
area
nucleus
which is
area.
accommodation center.
And divergent insufficiency is also very difficult to diagnose
Yes,
clinically.
ma'am.
So what were the features in that patient?
Ma'am, he was our house surgeon who started developing a sudden onset diplopia, mainly for FAR. So initially suspected any mild 6-nerve paresis like that, but then the deviation for FAR near I checked.
Esophoria was there or
Only for
esophoria?
FAR, ma'am. Yeah, he had
Esophoria.
a 6 diopter esophoria for distance and normal for near, ma'am. And eye movements were normal, no papilledema, no raised ICP, MRI was normal, so I put it as probable divergence insufficiency.
And your convergent retraction nystagmus patient?
Yes.
When the patient was looking up, there was retraction of the globe,
Yes,
but
that
no
is,
convergence was there.
yeah.
In fact, the eyes were diverging
Yes,
more.
yes. He had a exotropia also.
Okay.
I put the picture. He had a exo and
Okay,
this.
good.
Thank you so much.
Nice.